stress. It just doesn't feel right to do whatever. Or patient rights feel like they're vulnerable, they're in jeopardy. There's a conflict between autonomy of the patient versus noncompliance of the patient. There may be conflicts about treatments or goals. What should we do? Or decisional capacity and surrogate decision making or lack thereof. Who decides? What if the family is at odds with the patient? And then non-beneficial treatment may be requested. Can we say no? And end-of-life decisions when not all parties are in agreement. So Ascension Ethics last year came up with a helpful slide that just kind of summarizes the four main reasons for consulting ethics: conflict, concern, confusion, and crossroads. Conflict, is there disagreement between parties about what the right plan of care is or what's medically indicated? Concern, is there something causing distress, or are you struggling to reconcile aspects of the treatment plan with your conscience? Confusion, is there a lack of clarity around applying ethical principles? Is there ambiguity about the goals? And then crossroads, is the team having difficulty deciding what to offer, or is the patient or family having difficulty choosing between multiple appropriate options? And that's important because it really isn't fair to offer a treatment that the doctors really don't recommend or really are hoping the family doesn't choose that option. They need to be more honest with them. So when you're approaching an ethical issue, first you assess the situation, you analyze it based on principles, and then you act. The assessment, the first step is just what is the central ethical question? What is the key question that you're trying to address? And then who's involved? Who are the stakeholders? And then, of course, gathering the relevant information and then reviewing relevant moral and ethical principles, considering the options, and then arriving at a recommendation. And then implementing it, documenting it in the database. Um, so I know that you're all familiar with the core classical ethical principles of autonomy, beneficence, non-maleficence, and justice. The autonomy that reflects patient self-determination, the right to make decisions, to accept or refuse treatment. And this is often summed up in advanced directives or living wills. Beneficence, what's in the best interest of the patient? What would support the best quality of life? Non-maleficence, avoiding harm to the patient, where the benefits are far outweighing the burdens or harms of the treatment. And then justice, being objective, providing a uniform standard of care, fair allocation of resources, and stewardship. And then other principles that are important are dignity and respect for persons, truth-telling, proactive communication, and open and honest, kindness and compassion, and then proportional benefits greater than burdens as it affects quality of life. In other words, maximizing the benefits of treatment and minimizing the burdens, and ultimately relieving suffering. So here's a case. This is a homeless man who was found down, lethargic, dehydrated, with a glucose of 400. He was admitted to the ICU, given IV fluids, insulin, and electrolytes. He inconsistently nods yes and no to questions, but seems to resist nursing care and mainly just wants to be left alone. So obviously, before goals of care are addressed, we need to determine if he indeed even has medical capacity. And people can have capacity for preferences without having full medical decisional capacity. So decisional capacity is different from competence, which is a legal determination. The capacity is specific to the medical treatment or decision. For instance, someone can have the capacity to name a surrogate decision maker. If you ask them, who do you want to make decisions for you, if you can't speak for yourself and they consistently name a certain person, then you can proceed with a DPOA document completion. However, if you're asking them about open heart surgery or starting dialysis, they may or may not be able to fulfill all the requirements of decisional capacity. And what are those requirements? Well, first of all, it has to be informed, and which involves also the ability to understand the medical information. And how do we know that? Well, can they take in the information, manipulate it in their mind, and then tell it back to you in a way that makes sense? Decisional capacity also has to be voluntary, not coerced. It has to be a reasoned choice. It doesn't have to be necessarily in agreement with what you would want to do, but as long as it's a reasoned choice and a communicated choice. So if someone can't communicate, or if they're just kind of mumbling yes and no inconsistently, you can't say that they have decisional capacity. And obviously, illness, medications, delirium, or severe depression can affect decisional capacity. Now, informed consent, this is something that's required before all elective procedures or treatments, understanding the risks, benefits, burdens, and alternatives. It's discussed prior to the procedure, and the patient verbalizes or signs in writing a decision to proceed. However, in emergency situations, oftentimes people proceed without signed consent in order to save life or limb. If someone is hemorrhaging to death and they need blood, you give them blood. If they need surgery and they're not in a position to give consent and there's nobody available, then you do what you have to do to save their life, and then um, address other issues later, because there may not be the luxury of time to be able to make that decision. Somebody comes into the emergency department with a STEMI, they're going to rush them to the cath lab unless there's clear indication that they would not have wanted that. And it's also, informed consent is also a professional recommendation without coercion. Um, and a lot of times in medicine, people present options, but I think they present kind of the incomplete option. Oh, you have this, you need this. And there's not really a whole lot of discussion about, well, here are some other options. You could choose to get a peg tube because you can't swallow, or if you choose not to, then we would recommend hospice because of X, Y, and Z, for instance. Medical decision making. So the roles, usually, I mean, obviously the patient, but oftentimes the families involved or surrogate decision makers, and physicians play a big part because we can um, present information in a certain way that might be biased or might be spinning it a certain way. Maybe this is, or making our recommendation, which is okay to do, as long as people understand that if you're offering them a choice, then they can choose to accept your recommendation or they can choose to not accept it and do something different. Shared decision making, but who ultimately decides? And what if the patient or family decision goes against the doctor's wishes or even standard of care guidelines? What do we do then? And that makes people very uncomfortable because they feel like patients are denying themselves the opportunity to improve when something is treatable. All right, well, what if the patient is not decisional, like in this case? It's a homeless man who's lethargic. Who makes decisions and on what basis? Well, there's two ethical principles to keep in mind. One is substituted judgment. What would the patient want, do, or say? And the second is best interest standard. What is in the patient's best interest? So substituted judgment. Oftentimes this is found either in verbal or written statements of a patient's prior wishes. So an advance directive or living will would be a written example. Oftentimes these things are implied based on the life values of the patient. How did they live their life? What prior patterns and behaviors? Is this somebody who hated going to doctors and hospitals, and you know that they would not want to be tied down on a ventilator, et cetera? Or is this somebody who, yeah, they'll, whatever the doctor says, they'll do. So that can weigh into substituted judgment. It gives us clues as to what the patient might choose if they were able to speak for themselves. And oftentimes this is carried out by some sort of surrogate decision maker. The legal guardian has the most authority, followed by the DPOA, the durable power of attorney for healthcare, followed by the next of kin, which Michigan doesn't officially recognize this, but many states, such as Ohio, they recognize the spouse, then adult children, then parents, then siblings, and then others. And then other concerned parties. Maybe there's a good friend who has known the patient all his life, who maybe knows the patient even better than some of the family members. And you can take that into account when making a decision because it helps you get an idea of what the patient might choose if they could speak. But in order to be a good surrogate decision maker, you have to be an adult with decisional capacity. You have to be capable and willing to make decisions. You have to be available. and cooperative. You have to return phone calls. You have to show up or be willing to talk to the medical team. And you have to be appropriate, showing respect for the patient's wishes rather than railroading the patient's wishes. And it's important to note that the surrogate decision maker may be removed if they fail to meet the above criteria. So just because they say they're the DPOA doesn't mean you have to do everything that they want to do, especially if it would contradict what the patient would have wanted or if it goes against what would be in the patient's best interests. All right, so let's talk about the best interest standard for incapacitated patients. So basically, it's what a reasonable person would decide in the same situation. And it considers weighing the burdens versus the benefits of the treatment as they affect quality of life, with the goal of maximizing benefits and optimizing comfort and minimizing risks, harms, and burdens of treatment. And it would also meet the minimum threshold for acceptable care and honor the moral and legal duties to vulnerable patients. In other words, it would err on the side of life and limb and the overall well-being and quality of life of the patient. Now, quality of life is in the eye of the beholder, and um, especially in patients with dementia who can't really tell us as much. Um, one of the factors that to figure in is that certain treatments that are not excessively burdensome for people who can understand may be excessively burdensome for patients with dementia. For complications created by the patient's lack of understanding often change the judgment of how to best serve his well-being. The goal of ethical caregiving in a clinical setting is not to extend the life or postpone the end of the patient's life as long as medically possible, but always to benefit the life that the patient still has. So, in other words, quality of life. It's not just the goal of extending life, but it's trying to optimize the best quality of life for whatever time someone has. And many treatments can benefit or harm patients. Opioids is probably the classic example. Some families are resistant to using opioids for fear of harm or hastening death. I even had one family once say, well, morphine is just liquid death. Obviously, we had to do some education on how it's all in the dose. Obviously, if you give a huge dose, yeah, it could become liquid death, but most of the time, almost all the time, it's people do better with morphine. Also, treatments like invasive procedures such as surgery or ventilators or IR procedures, dialysis, and then other procedures, even things like pacemakers. If somebody's really, if they can't appreciate the benefit from it, then it would call into question, well, is doing the procedure, is that actually going to harm them in the long run or benefit them? So there's a lot of clinical judgment that comes into play regarding benefit versus burden and how it's not always black and white. Oftentimes it's a continuum of benefit versus burden. All right, so what about this issue of using opioids in dying patients? Probably years ago, they would have put a question on the boards that it implied that you only use IV morphine when someone's nearing end of life. And is that true or false? And I think the big fear behind that is, well, we don't want to hasten death, so we can't use morphine until they're actually dying. So do these medications hasten death? The answer is no. Initiation of treatment or dose increases with opioids or sedatives is not associated with precipitation of death when appropriate or proportional doses are used for symptom control. In other words, you're not going to give an opioid naive patient a huge dose of morphine for their shortness of breath if a smaller dose will do just as well, or if you haven't even tried a smaller dose first. And so this ethical principle of double effect, where the treatment purpose or motive is the relief of symptoms and suffering, and death after opioid administration is due to the underlying disease and not due to the medication. And we have an ethical duty to provide relief and comfort, especially at end of life. So here's another slide illustrating the principle or doctrine of double effect. So the actions can be classified as good, morally justified, or morally wrong. So an action with both good and potentially harmful effects is only permissible if the immediate act is not intrinsically morally wrong. In other words, the treatment is itself therapeutic or beneficial. Number two, the direct intention is to achieve beneficial effects, not cause harm. In other words, um, the harmful effect is a side effect, and you're hoping to avoid it. You're not intending to kill the patient by giving morphine. You are intending to control the symptoms. Uh, and then three, there's proportionate reason for tolerating the bad effect. The benefit is equal to or greater than the harm, or a less harmful treatment is not available or effective. And four, the beneficial effect is not achieved by means of the harmful effect. So it's all in the dose with opioids. Give a lower dose, you help with the symptoms. They actually live longer and live better when they are more comfortable. And so don't be afraid of opioids. Just make sure that you're dosing them in proportion to the symptoms. All right, now let's talk about conflict and unrealistic expectations, because this is what often drives ethics consults, drives moral distress among the staff. So I'll give a couple of cases here to illustrate some different types of conflict. This is a 64-year-old man who had an ERCP and developed pancreatitis, then septic shock, acute renal failure, respiratory failure, and heart failure. On hospital day 20, he was not improving. The son asked many questions and literally demanded hours of the ICU team's time. He also contested blood transfusions and refused to allow dialysis initially, delaying initiation of these by several days. Palliative care was consulted for goals of care. The son met us at the door and initially refused to let us in, but with further education about palliative care, he did allow the support aspect of it, the extra support, but he didn't want us, doing any kind of symptom management. And of course, the patient was full code. 2 days later, he fired palliative care after the patient had received one dose of fentanyl, a very low dose, which had actually been ordered by the ICU team. And he also fired several ICU residents, nurses, and attendings. And of course, the staff was very frustrated. Another case, 72-year-old man with COVID refuses a ventilator, has worsening oxygenation on maximal high flow oxygen for 2 weeks. His family disagrees with his decision to avoid a ventilator and insists that he be intubated if he worsens. Or a 66-year-old woman with PVD, heart disease, heart failure, end-stage renal disease on dialysis, and says she doesn't want to continue dialysis anymore. Her husband cannot bear to lose her and insists that she continue. She has hypotension and worsened pain during dialysis. And to her and to the patient, to the dialysis nurse, it feels like it's torture. And sometimes you have conflict with specialists. 72-year-old woman admitted to the ICU after urgent cardiac cath for STEMI cardiac arrest on a balloon pump, ventilator, pressors. The daughter arrived and said that her mom would never want to live on life supports and requested withdrawal. The cardiologist objected, stating, "I am ethics for my patients," and that it was too early to prognosticate and the patient needed more time. He reversed her DNR, making her full code again. 2 days later, as the patient had developed renal failure and was not improving neurologically, the daughter again requested DNR and ventilator withdrawal, comfort care, which was honored after multiple discussions, including with cardiology. The patient died comfortably. All right, so let's talk about types of ethical conflicts. So at end of life, these often involve medical decision making. In other words, who decides, goals of care, what can or what should we do, values and priorities, and the use of artificial life supports. Do we avoid them? Do we continue them? Or do we withdraw them? The parties involved, stakeholders, so patients, family, next of kin, surrogate decision maker, which can include an informal decision maker or DPOA or guardian, and then staff, the attending, the specialists, the nurses, sometimes even risk management can get involved. So the main question is it ethical to do whatever or not to do whatever? And always ask why. When there's a conflict, what's the underlying reason or the underlying factors that are making the patient or the family say or do what they're doing? It may be unmet expectations. Maybe the patient is medically worsening or there are complications. and the family is not liking that, and they're pushing back, and they're wanting explanations, and they want everything to try to reverse those things. Or maybe there's been poor communication. Maybe they haven't been kept up to date regularly during their ICU stay. And so when they come in and see their patient looking, or see their relative looking so bad, they say, well, what did you do to him? He was fine a week ago. Or maybe there's perception of medical negligence or error or poor care. In this era where there's nursing staffing shortages, patients might have delays in attention during their hospital stay. And so that doesn't usually sit well with family members or their patients. Um, and then people might be in the early stages of grieving. The first two stages of grief are denial and anger. And that is often why there's conflict or resistance or the so-called difficult family. Family's not ready to lose their loved one. And so they're going to try to do everything they can to try to hope for a miracle. They may believe in miracles against all odds. The patient's prior wishes for everything to be done or not. In other words, patient says to their family at some point in the past, don't ever pull the plug on me. Then family's going to want to do everything, and they're going to be very resistant to end of life. Maybe the patient's mental state or mood. Maybe they're either unrealistically optimistic, or maybe they're very depressed and just ready to call it quits, even though there are things that could be treated. So what is the best way to deal with conflict? The first thing is to listen. Try to understand where they're coming from. What's the background? What are the beliefs? What are the values of the family? What are their prior experiences with family members or friends that have been in similar situations? What are their hopes? What are they hoping for? What are they afraid of? What are they anxious about? And where might they be in the stages of grieving? And then show respect. Always respect them. Listen, respect, try to clarify misunderstandings, often asking the phrase, help me understand what you mean when you said this. Because that's an informational question that sounds non-threatening. It's not a challenge. Well, what did you mean by that? It's more like, well, I just really want to know. Help me understand where you're coming from. Avoid harms to the patient. Don't offer medically inappropriate treatments. If you and the other medical team do not think that the whatever treatment would be advisable, then don't offer it, because it does. If you offer it, they will assume it's a reasonable option, and if they choose it and then you resist or push back or try to talk them out of it, they're going to get confused. They're going to feel like they've been getting mixed messages, and that usually doesn't go over well. The concept of negotiating a time-limited trial with specific goals is a very helpful way to deal with conflict. That way, it gives people more time to adjust to the new normal, to adapt to the information that's been given, to emotionally prepare for end of life, which takes time. And it also gives them a chance to see if the medical treatments are actually working or not. In other words, is the patient actually getting better? Or are they just being maintained on the artificial life supports? Or are they getting worse despite that? And an ICU attending once said that if someone's not improving, in other words, if they're just kind of maintaining on the life supports, then they're actually getting worse, because every day that they're dependent on that, they get weaker and weaker. And it's very important to communicate regularly with the family, because then it helps prepare them if and when the time comes where they do have to make that decision about vent withdrawal and comfort care. So I like to start conversations by asking questions, because that's less threatening. And then by kind of generally focusing on what was life like before the hospital, what was the health like, what trends have they observed, and then what does the family or the patient know about their medical conditions? And what have the doctors said about how things are going right now? And have the doctors talked about what to expect in the future? And again, using simple terms rather than medicalese. Um, who's their decision maker? What have they talked about? What's important to them? And then finally, if their heart stops despite medical treatment, do they wish to allow natural peaceful death or undergo attempted artificial resuscitation and further life support machines? And then where do we go from here? And you've probably seen this before. It's the house model where you first establish the relationship, then you hear the patient's story, then you give the medical information, and then make a balanced medical recommendation and collaboratively make a decision together about the best path going forward. All right, so I'd like to focus on two specific strategies at end of life. Um, Informed non-dissent related to code status and the non-beneficial treatment or medical futility. All right, so this case is a 90-year-old with advanced dementia and a massive intracranial hemorrhage who's full code, dependent on a ventilator, dialysis, and vasopressors. On admission, the family had stated, do everything. Code status was discussed, including risks and benefits and burdens, and using the GOFAR score for the odds of CPR success with neurologically intact. The family was unsure, they wanted more time, and they can't bring themselves to say, don't do CPR. So I don't know if you've heard of this. This is called the GOFAR score. And there's a calculator. It's also on MD Calc. You can Google it. And it factors in patient variables and comes up with a score translated into a percentage likelihood that someone will actually not just survive CPR, but be neurologically intact. In other words, able to interact and able to do some things for themselves. And it breaks it down into a few categories: less than 1%, 1 to 3%, and 3 to 15%. So I found that the GOFAR score is helpful if the patient is full code but has a very low likelihood that they'll have a good outcome. And so sharing this information with them, saying you may not be aware of this, or but CPR involves chest compressions and shocks and putting them on an artificial life support breathing machine. And in this person's situation, their likelihood of surviving all that and being able to interact and meaningfully and function on their own is less than 1%, 1 to 3%. And if, would they still want that, knowing that that is the expected outcome? And so sometimes people will change their mind and say, no, I don't think I would want that if the odds are that low, because they're used to what they see on TV. And on TV, 90% of people survive and are cognitively intact. All right, um, so we'll get into some of the nitty-gritty about code status in a minute. So here's another case: a 59-year-old alcoholic with liver disease, history of meth use, admitted to the ICU with acute respiratory failure due to COVID, pneumonia, and ARDS, shock, both cardiogenic and septic. He's on a ventilator, FiO2 100%, vasopressors, and sedatives to prevent alcohol withdrawal. He has acute kidney injury with severe metabolic acidosis. So he's on a bicarb drip, and he ultimately required CRRT dialysis. And on admission, the family said, do everything. Unfortunately, he has no DPOA, and his next of kin is a 16-year-old daughter. His ex-wife is uninvolved. His sister refused to make decisions or return calls. He does have a niece who would be his nearest next of kin that's of legal age, but she also refused to make decisions. So what do we do now? Who can decide? All right, so levels of consent to medical recommendations, and we'll use the code status as an example. So informed consent, which is where you inform them and they verbalize a reasoned decision. So such as family stated no CPR if the heart stops. Informed assent, which is where where you inform them, but they are willing to go, they won't say what they want to do, but they're willing to go along with your recommendations. So the family couldn't bring themselves to say no to CPR, but they agreed with the physician recommendation for no CPR. In other words, allow natural death if the heart stops and the person dies. And then the next one is informed non-dissent. Notice the double negative. So, and this is where you inform them and they don't disagree. They don't object. So family voiced no objections to not doing CPR. If you ask them, what do you want to do? They'll say, do everything. But if you explain what everything might look like with CPR, and what the odds of a good outcome would be and how you're recommending against CPR, they don't voice any objections to that. And so you can change code status to DNR based on the principle of informed non-dissent. Now let's talk about futility. really what we mean is non-beneficial medical treatment. So this is treatment with an unacceptable likelihood of achieving an effect that the patient has the capacity to appreciate as a benefit. And it would involve excessive effort or finances, excessive medical intervention with little prospect of altering a patient's ultimate clinical outcome. In other words, prolonging the dying process. And there are factors involved. What are the patient goals? Futility is in the eye of the beholder. Patients' families may say, well, she's alive, so she's getting some benefit from this. So therefore, we don't think it's futile. Because after all, where there's life, there's hope, right? Um, so patient and family perceptions of what's benefiting the patient or not, physician clinical judgment and prognostication. There may be disagreements among the cardiologist, the nephrologist, the intensivist, or the hospitalist, or the palliative care team. And then medical evidence and clinical guidelines. How does medical treatment fit in with that? And then other issues, financial issues, legal issues, media issues. Sometimes, like for instance, a few years ago, there was the Charlie Gard case. That obviously the parents didn't think that child, that the treatment was futile, and they were trying to, go anywhere in the world where he could get treatment. Whereas the doctors were saying, no, this is futile. This is not something that he's ultimately going to survive. So why should we be doing all this? So these are factors that factor into the whole concept of is something futile or beneficial or not. So another way to look at it is medically inappropriate treatment or non-beneficial treatment. And you need one or more of the following criteria. Number one, failure to achieve medical and physiologic goals. So that makes it a little more practical. If someone's on a ventilator, are they slowly becoming less and less dependent on the ventilator? If they're on dialysis, is it temporary, or is this going to be the new normal? If they're on vasopressors, are they slowly able to wean off the vasopressors, or do they remain fully dependent on them? Are there disproportionate burdens and insignificant benefits? How is this causing pain and suffering to the patient by being on all these things and having all these lines and blood draws and invasive procedures? And is this ultimately prolonging the dying process? In other words, does the patient have a terminal prognosis? Is this something that, short of the life supports that they're on, they would have died long ago, and we're just kind of extending their life, which really means extending the dying process rather than helping them get better. And I think that's the bottom line. Are the medical treatments helping the patient improve? Because if they're not, then they're just prolonging the dying process. And if there's uncertainty, if it could go either way, well, then the time-limited trial is reasonable. If not, then a decision at some point would have to be made about when to discontinue those. Physicians are also not obligated to offer or provide treatment that they believe is medically non-beneficial. And that's determined by two physicians, often with input from ethics, although it's not mandatory. If there's any doubt, it's always recommended to get input from ethics. There is the obligation to inform the family of non-beneficial treatment, and they have the option of transferring care elsewhere if they so desire. Many hospital non-beneficial treatment policies will specify a certain time period, like 7 days or 10 days or something like that, where the life supports will be withdrawn at the end of that time period, unless the family chooses to transfer them elsewhere. Now, in my clinical experience, I've never had, Henry Ford or U of M accept somebody who really is that bad off and not likely to benefit from additional treatments, with the exception being something like ECMO. Like during COVID, we had a young lady who needed ECMO, and they moved her to U of M, and she ultimately survived. But almost all the time, the accepting facility is not going to accept the patient because they can't necessarily offer them anything that we're not already doing here. Okay, so here's an example of changing code status to DNR. When somebody can't speak for themselves, these are some reasons where you can withhold CPR from them. Number one, if there's strong evidence the patient would not have wanted it, such as advanced directives, prior statements, or life values. Number two, CPR would either fail to benefit or would likely harm the patient. The risks or burdens are out of proportion to the benefits. The treatment would prolong irreversible dying process, and there's no physiologic rationale or benefit of CPR. A good example of this is someone who's on a ventilator, on CRRT dialysis, and also on 3 vasopressors at maximum doses. So basically, they're already being chemically coated. So when their heart stops, the CPR really isn't going to change anything. It could, and it might even harm them in the process. Another example would be somebody who has severe osteopenia. Maybe they've been on steroids for COPD, and their bones are just really brittle. So you know that when you do CPR, it's going to break multiple ribs, potentially cause a pneumothorax. Maybe they've already had a pneumothorax in the past. And so CPR could actually be more harmful than beneficial. Or someone with end-stage heart or lung disease who has a cardiac arrest. If they already have end-stage heart disease, if you resuscitate them, it's not going to change their underlying disease process. And the end result of end-stage heart or lung disease is that eventually their heart is either going to stop or they're going to stop breathing. And then also, we factor in considering the well-being of the whole person and the proportional benefit versus the burdens. And there's no obligation to provide medically ineffective or medically non-beneficial treatments which do not respect the human dignity of the person. All right, so going back to our case where the patient's family wanted everything and the patient was on multiple forms of life support and doing poorly. There were multiple family meetings to discuss goals. The daughter agreed with the medical recommendation for DNR, so by informed assent as well as non-dissent, but she wanted more time. So we recommended a time-limited trial with specific goals or signs to look for to help the family make the decision for continuing versus discontinuing life supports. And ethics was also consulted. So it's helpful to give people some anticipatory guidance of, well, this is what we're looking for. And if we don't see these improvements, then at some point you'll have to make a decision on how much longer to continue or when to discontinue the artificial life supports. So in this case, after 3 weeks of multiple life supports, 100% ventilator, CRRT, pressors, bicarb drip, his acidosis worsened, and he remained unable to wean. He was remaining encephalopathic and obtunded despite no sedatives. So I think all of us would look at this and say, yeah, he's dying, and there's really no hope that he's going to come off these multiple life supports. So withholding or withdrawing artificial life supports is permissible as an ethical, moral, and legal option, which was established years ago in the Quinlan and Cruzan landmark cases. Removal of unwanted or burdensome artificial devices to allow natural death from the underlying illness or diseases is not murder, suicide, or euthanasia. It's merely allowing natural death. Catholic ethical and religious directives support withdrawal of life-sustaining treatments if the burdens are disproportionate to the benefits, if the patient would not have wanted the artificial treatments, and if medical treatments are no longer effective. In other words, they're non-beneficial, and they harm the dignity of the person. There may be some controversy where there's disagreement among the medical staff or family. There may be conflicting values, judgments, opinions, and goals. And that's where time and multiple family meetings can be helpful, because as time goes on and the family begins to see that, yes, everything is being done and they're still not getting better, it makes it easier for them to be more at peace with a decision about limiting the medical treatments. And some examples, CPR, ventilators, other non-invasive oxygenation like BiPAP or high flow, vasopressors, balloon pumps, temporary pacemakers, dialysis, and even artificial nutrition and hydration or medical nutrition therapy. It's not the same thing as food. And when people are very sick, they often don't feel hungry, and so they're not suffering by not eating. In fact, in the dying process, the body actually shifts to a catabolic state, and they can't even use the nutrients that they're getting. All right, so here's some strategies. Early, clear, and honest communication about the condition and about prognosis. Listen and respect the patient and family, and try to understand their perspectives and their background. Recognize the underlying emotions that are behind these statements or requests that they are making, and respond with empathy. Recognize the underlying psychosocial and spiritual and cultural factors that may be driving some of their requests or demands or decisions. Explore the benefits versus the burdens related to quality of life. In other words, how are these treatments or these procedures, how will they affect comfort? Well, will they cause a lot of suffering or pain? What's the likelihood that doing those things will actually help them either get better or feel better? And then align the treatments with the patient goals and values. Agree or negotiate a time-limited trial with specific goals in mind for the family to look for, and then schedule follow-up family meetings, because after all, it's a process, not an event. The goals of care is not a one and done. It's a series of discussions and a series of decisions over time based on how the patient is doing. So, getting back to our case, we had a final meeting with the daughter by phone and then in person. Clinical situation was explained again, noting the signs of the patient slowly dying despite aggressive life supports and treatments. In other words, he was getting worse, not better, despite everything being done. There was agreement by both the ICU attending and the nephrologist to simultaneously stop CRRT dialysis and vasopressors. The daughter voiced assent and no disagreement with stopping these, but she was still uncomfortable with pulling the ventilator out. So he did die shortly afterwards while still on the ventilator, but he was comfortable. So ethics agreed that multiple criteria were satisfied for withholding and withdrawing treatments. And this is an unrepresented patient regarding medical decision making, because there really wasn't a legal age person willing to make decisions. It was his minor daughter. However, decisions were made according to the patient's best interests and according to what was medically reasonable as well. At least two physicians independently agreed that treatments alleged to be medically inappropriate met the criteria, which permitted the decision to withdraw the treatments. All right. So in summary, I hope this has been helpful in terms of understanding the causes and nature of ethical conflicts at end of life, and reviewing and applying ethical principles to cases, focusing on issues of informed consent, medical decision-making, and limits. Also, the two key standards of substituted judgment regarding surrogate decision-making and the best interest standard for unrepresented patients. Also, DNR and withdrawing life-sustaining treatments, and strategies for dealing with conflicts, including the time-limited trial, and an approach identifying and approaching requests for non-beneficial treatment. Thank you. Are there any questions?
I have a question.
Yes.
This is just, the timing is perfect. I was trying to get a sense yesterday. We had a patient about like the fitness of a DPOA as an appropriate substitute decision maker, and also when removing a person. Basically, the case is a 96-year-old lady who was voicing her desire to die all day, and with worsening oxygen demands or increased oxygen demands, now on high flow. And then they pull her not incapacitated son, but a son who is her DPOA, but has probably a cognitive functional level of a 12-year-old. And I was questioning how we determine the fitness of someone like that in this case, and especially in the case of a patient who's able to verbalize their desires, and he goes, like you said, it's like supposed to be reflecting the patient. And the
Mhm.
argument was that he's the DPOA. And the argument was also that like she didn't have capacity as she was dying. And I said, don't we all lose capacity before we die, technically, because we're dying? And I felt it very ethically, you know, wrong or struggle in that case. And I couldn't get a real, like, I guess, answer even looking into like precedent for that kind of thing.
Yeah, so if the patient is able to indicate clear and consistent wishes, then that takes priority over even what the DPOA says. A lot of families will pull the DPOA card. Oh, I'm the DPOA. You have to do what I say, while
Yeah.
the patient can still voice their opinion. And no, we can't do what they say because number one, the patient's able to verbalize a choice or wishes. Number two, uh, the family's wishes can't contradict what the patient would have wanted. Um, in other words, if the DPOA is saying something different than what the patient has said, then we're obligated to follow what the patient would have wanted. And I guarantee there'll probably be a board question on that, where they'll say, they'll present a scenario like that where the patient has expressed their wishes and the family comes in and said, I'm the DPOA, you have to do it this way and not that way. What should you do? They might, and one of the choices might be consult ethics, which is always important. But when those questions are asked on the exam, they always say, well, what would you do next? And so
Right.
usually it's something like, have a conversation and try to figure out where they're coming from first, and then
Well,
try to
sure.
see if there's some kind of way to get everyone on the same page. And then if you can't, then you call ethics. But basically, ultimately, they want you to support doing what the patient would have wanted and supporting their autonomy and their self-determination. And then you apply the same standard of decisional capacity to the decision maker.
Okay.
The DPOA, if they can't take the information in, manipulate it in their mind, spit it out in a reasonable, coherent way, and if they're not willing or able to make a decision, or if what they're saying goes contrary to what the patient would have wanted, and there's no good reason for that, then you don't have to follow the DPOA's advice or instructions. You can
Yeah,
remove them as DPOA.
yeah.
But if you do, I would recommend having ethics involved just to have that neutral third party. And it also gives you a little bit of legal support if it ever
Yeah.
came to court.
This was very time sensitive and in a 96-year-old, and so there wasn't time for that extra part of it.
Uh-huh.
And then her capacity had been questioned the entire admission, but no
Oh,
one had ever activated the DPOA,
oh.
which until she wanted to die. And then, you know, but I was just kept told that, like, yep, you can, like, 40 minutes ago she had capacity. Now she doesn't. So we defer to the DPOA. And I was like, so 40 minutes ago when she was saying, I want to die all day to every staff member, we kind of took that as, reliable. And then once she became more oxygen requiring and wasn't able to function as well, we literally, not we, the team flipped the switch and said the DPOA gets to decide completely, like gave 100% of the decision making to him. So it was a weird case.
Well, I think and the key there is that the patient was consistently saying the same thing to
Yes.
multiple different staff members. So that would lend an awful lot of support for us following her wishes. And
Yeah.
basically, we're not killing her. We're just not
Letting her.
escalating care and not doing things that she wouldn't have wanted. If her
Yes.
body's in the dying process, A, we want to make sure that she's comfortable and that the family knows that she's dying and offer them emotional support.
Thank you.
Dr. Trexler, I think I
Yes.
know the answer to this, but I want to hear what you have to say. So a lot of times, there's no other way to get around a difficult situation than time spent with the family and with the patient asking questions. So how do you balance that when you have a busy day?
Um, well, I mean, you
Not
can have
even.
a goals of care discussion in as little as a few minutes. It doesn't have to take an hour every time. Um, and sometimes when you're in a family meeting and you begin to sense that things are kind of going in circles and they're beginning to say the same things over and over again, then it's probably time to politely excuse yourself and say, acknowledge that, yeah, these are difficult decisions. Sometimes it's helpful to kind of talk together as a family, and we're going to step out and give you some time and space to think about everything. And please let us know have, when you want to talk some more, if you have other questions, and we'd be happy to come back and talk with you. So being patient, being willing to give them time and space to think about everything. Because it doesn't take that much time to give the medical information and acknowledge how hard it must be to hear this and and talk about quality of life and options. It just takes a few minutes to do that. But families, if they're not ready to make a decision, then whether it's 10 minutes or an hour, they're still not going to make a decision. So to save yourself time, you can, once you sense that you've basically said everything you need to say and that they just need more time to think about it, then you can politely excuse yourself.
Mike, this may be more of a process question for the fellows, but when we reach out to the ethics committee, what should we be expecting? How should they communicate with us? What is the end product or outcome that we should get from an ethics consultation?
Yeah, that's a good question. So hospitals, I think all hospitals have some kind of ethics committee, and it may look different at different hospitals. Some are more formal, some are an actual committee, others are just an ethicist or a clinician who has extra training in ethics. And so the first thing they're going to want to know is what's the ethical question? What's the central ethical question? What is it that where there's conflict or dilemma or causing some moral distress? And so there'll usually be a conversation between the ethicist and the clinician about the situation, and then they'll look at the chart and they may or may not, talk with family or see the patient. It depends on the situation. And then they'll try to boil it down to what are the core ethical principles that are involved here, and they'll make some kind of a helpful recommendation going forward, saying, okay, in light of this patient's goals or wishes, or in light of their clinical scenario or their prognosis, and in light of these ethical principles, here's what I recommend. Number one, it's okay to allow natural death, and and change to a DNR as long as two physicians agree and as long as the family doesn't object. Number two, it's also ethically permissible to withdraw the artificial life supports because it's become clear that they're not actually helping the patient get better. They're merely prolonging the dying process. And number three, the patient wouldn't be able to even appreciate a benefit of the medical treatments because they're obtunded and not on sedatives. And number four, it's okay to set a time limit and say, or for under the non-beneficial treatment policy, our hospital offers 7 days until the life supports are unilaterally withdrawn. And this gives the family time to adjust to the situation and call family in from out of state, or try to arrange transfer elsewhere, something like that. So a good ethics consult will have very specific and helpful recommendations that support what would be the best medical care or support the best interest for that patient, and also not violate ethical or moral or legal principles. And basically, it gives you some support for your clinical work and allows you to say no or set some limits without feeling like you're out there all on your own and don't have anybody covering your back. And so then they'll either put a note in the chart or they'll call you, or both, after the consult is done.
Good. Thanks for that, Mike.
Mhm.
Any other thoughts or questions? Okay. Well, thank you again for sharing with us today.